Good afternoon. Happy to be here. Oh, it's morning still. Afternoon, yeah. So I'm standing here before lunch. Luckily for you, the data is really scarce regarding the concurrent use. But unfortunately for the patients, we have a lot of unknown areas. Here are my disclosures. With TDM1, we do have some preclinical data. The emtansine is the antitubulin group of drugs, and we know that the group alone is a potent radiosensitizer used alone. Combined with trastuzumab as an ADC, it targets mainly selectively HER2-positive cells. And we also have some data from other preclinical studies that the more you have HER2 positivity, the more the drug will affect, as seen here in this slide. The emtansine alone with radiation has effects to all drugs, but with the ADC combination, it mainly targets only the HER2 positive cell lines. So what we know about the efficacy, it increases apoptosis as itself, but also it increases the number of cells in the radiosensitivity to M phase in the cell cycle, which is radiosensitive, as we know. Well, we heard about the KATHERINE trial already before today for patients with residual disease after neoadjuvant therapy. The concurrent radiotherapy was permitted, and actually the number of patients who had concomitant treatment is quite large, over 600 with TDM1 and almost 600 with trastuzumab alone. So we should have good data, but unfortunately we do not have. The reported pneumonitis rate was, as we heard already today, it was very low in both groups. The acceptable pneumonitis toxicity in radiation oncology is under 5%, so this was way below that limit. And also the grade 3 skin toxicity was really low in both groups. You have to dig into supplementary materials to actually have anything out of these trials regarding the radiotoxicity. And there is one line which states that the dermatitis or skin radiation injury was very low in both groups, which cannot be true. We know that grade 1 is very common, is at least 80-90% of patients have some toxicity, some mild inflammation in the skin. So if there are people here who are involved in the KATHERINE trial, I hope you can encourage some data digging more about the results and maybe the 5-year toxicity. How does the skin look at 5 years? So there we would have sufficient data to really be sure that this is safe concurrently. The ATTEMPT trial was an adjuvant trial between TDM1 and trastuzumab for stage 1 breast cancers, no neoadjuvant therapy in this trial. And the radiotherapy was given concurrently with TDM1 and concurrently with trastuzumab, but not with paclitaxel. The numbers here are a bit different because this was randomized 3-to-1. So we have more patients in the TDM1 group than in the trastuzumab group regarding the radiotherapy. Almost all patients had whole breast radiotherapy. More than half had conventional 2-grade fractionation, and most of the patients also had the boost. So Sarah already showed this slide. The toxicity was acceptable with both groups, a little bit higher in the TDM1. Grade 2 was 34%, and with the trastuzumab only 23%. This was not statistically significant, but the number in the trastuzumab group is quite low. And what we see, of course, with conventional fractionation, the grade 2 toxicity is much higher than with hyperfractionation that we see in the clinic nowadays. And I suppose that almost all of Europe now uses the 3-week schedule for breast. Pneumonitis rate in this study was also very low in both groups, and no difference in the ejection fractions. There are some prospective data publications. These are small numbers, 35 patients in the first one. They had weekly visits for the physician to look at the breast and skin. Most here had 50 grade treatments, and they had a quite high number of grade 2 toxicity, 66%, and at grade 3, 9%, which is unusual, and none had long-term skin toxicity, so the long-term results were acceptable. And another other one was only 14 patients with very low number of grade 2 toxicity. So this is not clear. Well, we switched to intracranial. No randomized trials, but the data from the patient series is quite consistent. The concurrent use with TDM1 and stereotactic brain radiotherapy, it increases the risk of radionecrosis, both symptomatic and asymptomatic. And hazard ratios are estimated in different trials. The range is from 2.5 to even 13.5, probably lies somewhere in between those numbers. And also we know that the radiotherapy at very short time span from the infusion produces the highest risk. You can, there is some risk using sequentially, but concurrently is the highest. Whole brain radiotherapy is the number we use it nowadays is very low. And I don't know if there is a good indication to use it concurrent with TDM1, because as we heard, both TDM1 and TDX, they have a quite good intracranial penetration, and it might be sufficient to use with the drugs only and not use the whole brain radiotherapy, or save it for the absolutely later lines. Well, the story with trastuzumab deruxtecan is very short. I couldn't find any preclinical data. Within these Destiny trials, in PREST-02 and PREST-03, palliative radiotherapy was permitted during the treatment, but it is not reported in either of these trials. Unfortunately, I don't know if they had used it or not. So with this drug, there is absolutely a massive lack of data regarding the safety and efficacy with radiotherapy. So when these adjuvant indication trials are planned, I hope that the toxicity with radiotherapy is followed quite intensely. With sacituzumab govitecan, there is one case report with concurrent use with whole brain radiotherapy, and within this patient there was no excess toxicity and rather good intracranial response. But this is the only thing that can be found in PubMed at the moment. So we also need much more data when this drug will probably go into earlier lines as well. So my final slide, with TDM1, the half-life is 4 days. So if you wish to use in intracranial radiotherapy concurrently, maybe you can wait at least 3, 4, 5 half-lives. That's something we can discuss here. With adjuvant breast radiotherapy, the concurrent use seems to be relatively safe, but I have to ask, is there a rush to start the treatment after surgery already, or could you use only trastuzumab during the radiotherapy? It's 3 weeks, maybe later only 1 week, within 5 fractions. So is there a clinical need to rush the TDM1 or later the TDXD? But mostly lack of data regarding the TDXD at the moment, as well as sacituzumab govitecan. Thank you.